Thank you all for coming out today, and it was truly several of the slides are wonderful segues into some of what we'll talk about today from Dr. Rosenfarb. Specifically the last one that had the circles and talked about a lot of the things you can do to stave off dementia and the physical component and the changing of the behaviors that we'll talk about. But I got to talk about my grandmother first. And it's just sitting here, I've had wonderful memories of Grandma Kilpatrick, Grandma Kay, a true matriarch, my mom's mother. She lived to be 97 years old. In the last 10 years, she lived with dementia. Grandma Kay growing up was truly the kind of the picture of health. You know, when you're a kid, you don't think about these things. But she, you know, back in the 60s, she had an exercise bike in her house, and she rode it regularly. You know, she cooked, you know, healthy food all the time. She was very social. She was, involved. Every Sunday we'd go over to her house for dinner, or lunch between, church services, and she was very involved with her church as well. She was an amazing woman and was truly the matriarch of the family. And that last 10 years of dementia was tough on all of us. But it was, my mom has 3 sisters, and they had a home next to my mom's house, and mom and dad, and they acquired that. And it was before assisted living was really, going full guns back in the 70s. And so they had a caregiver that would come in every day, but every evening for 10 years, one of my mom or my aunts stayed with Grandma Kay. And I think, for me, it still touches me. It's that sense of respect and that sense of honoring somebody who lived a life so well lived and gave to so many people, and to see people giving back to her at that moment. And I think as I segue into what we're going to talk about today, there's a lot of things that she did very, very well to allow herself the ability to live as long and fruitful a life as she did. And then her mind started to give out some before her body did for 10 years. But one of the things that Dr. Rosenfarb talked about is that incident that occurs. For Grandma Kay, it was driving. And so she drove well into her 80s, and late 80s. But I remember literally the day when they took Grandma Kay's keys away. And I came back, and she was still living by herself. And I came back home from college, and I remember opening up Grandma Kay's refrigerator, and something had changed, and there were vegetables that were gnawed on, and it was just something had happened along those lines. But anyway, maybe I just needed to share that with you guys today, but it is something that when I think about Grandma Kay, I think about the influence that she had, and I think about how that juxtaposes with what Trestle Tree is doing today. And so what I'd like to do is share with you a little bit about what we do, the art and the science of how people change behavior that we've been involved in for the last 17 years. But then also be able to talk about specifically with seniors and retirees that we've worked with and what that may look like. So we'll get started here. I won't spend much time on the company, but just to give you an idea, as I mentioned, we've been around for a while and came out of a retail pharmacy setting. And so I used to own some retail pharmacies in Northwest Arkansas. I live in Fayetteville, Arkansas. And it was our customers who were coming in to our pharmacist directly from their doctor's office and could tell the pharmacist what the doctor just asked them to do. You have to take your medication, you have to get a screening, you have to lose weight or stop using tobacco, whatever that might be. And while most people knew what to do, the majority of people really struggled with actually following through with the physician directives. And so I started a conversation between my older brother Dan, who's a family physician in Fresno, California, and a good friend of mine, Clint Gabbard, who's a co-founder of Trestle Tree. He was a psychologist out of Notre Dame at the time. And it was really about how can we help people who know what to do but aren't able to follow through. And I'm sure if I ask anybody if that resonates to you, nobody would raise their hand here in the room, I'm sure. But there are a lot of people that resonates with. There's that sense of knowing what to do, but really struggling with how to actually do it. So that's where we started this conversation, and we have come up with a program that works with a lot of different populations, employers, health plans, clinically integrated networks, retirees. And so it really is a full continuum of health that we try to help people move forward in their health. So whether it's something that's prevention and wellness, or a disease such as diabetes, we're moving in and doing some things specifically with Foreign Service Benefit Plan around the opioids that we'll talk a little bit about today as well. But again, it's about changing behavior, and how do you do that? Our mission, vision, values, this is a busy slide. You know, it's never intended to be a busy slide, but it actually is. But the two things that I wanted to draw your attention to under the values of Trestle Tree is, one is that we really believe that change is advisable and achievable for everyone. And I think advisable, most organizations would buy into, but advisable and achievable? What if you're not motivated? What if you've given up hope that you can change? Is there still opportunity to change behavior? So that's one that I wanted to bring. With Trestle Tree, we believe that truly everyone can change behavior. You just have to approach it a little differently. The other one is that I love, and I think it wraps up things about Trestle Tree very, very nicely, is that Trestle Tree celebrates life as a mosaic, rich with messiness, meaning, and texture. And it's that messiness of life that healthcare oftentimes doesn't have time for, not quite sure what to do. So my older brother Dan is the most compassionate person that I know. And he still says, Ted, I know the questions not to ask my patients. I don't have time. I've got to see 30 patients in Fresno, California to make ends meet. He said, I got to go to the next room. And so it is a torture for him not to lean in to the messiness of somebody's life, but he understands he doesn't have the time. So that's part of what we lean into and train health professionals. How do you sit with the messiness of life? Not try to clean it up or avoid it, or wish it wasn't there, but in the midst of somebody's messiness, be able to connect with them, understand what their physician has asked them to do, and come up with strategies on actually how to move forward. So our core expertise at Trestle Tree is really, how do you help people change behavior who are stuck, as I mentioned, that don't want to change sometimes, or feel like they're incapable of changing. That really is the focus that we've had from day one. How do we give skills to health professionals to help people move beyond that? We train a lot of different health professionals today, and so it's really the full spectrum. We do have medical social workers that we have on staff that we've trained, and pharmacists and registered nurses, and you can read a whole host of those that are there. But the training that we put into them is really what makes the difference with Trestle Tree. And so the training, I'll pause here for a minute. Clint Gabbard, who is the co-founder, is pretty cynical, actually. He's not in love with his own profession of being a clinical psychologist. He's not somebody that is in love with any one theory or in psychology or behavior change. And so what it allowed Clint to do is take bits and pieces of different theories and come up with a unique training that was very pragmatic on how to give the skills to people to help people change. If somebody's pretty motivated to change, good accountability, a caring healthcare professional, good information at the right time is really what they need. And there's wonderful resources that are out there today. We've talked about online apps and different programs that come out of the doctor's office or the health plan. So what we're really focused on is, what about that population that again is struggling, and what do you do with them? A caring healthcare professional and to tell somebody louder more often what to do doesn't work. So this training is essential. So we put 200 hours of training into our health professionals with PhD psychologists that truly learn new skills on how to build relationships of trust and earn the right to influence. Healthcare is really good about diagnosis and really good about giving you the right information at the right time. Where it breaks down at times is what happens if that's not enough. And that's where we step into that gap with someone who's trained. And what this looks like is somebody who comes alongside. So we have done this face-to-face in person. We've done this over the phone. We've done this through video conferencing, through email. So we're pretty flexible as far as the communication modality. But it really gets down to, how do you build relationship with somebody enough that they put their stuff out on the table? And I'll tell you a quick story about how kind of the heart and soul of Trestle Tree started. Is back when I had the pharmacies, and I sold those back in 2000 and started Trestle Tree. But we had 4 of our customers come in. So Clint came down from Notre Dame and did 1 day of training, not 200 hours, just probably 5 hours of training with 2 of my pharmacists. And we had 4 of our customers come into the next day into my office, and 2 had asthma and 2 had diabetes. And the pharmacist knew our customers and just said, hey, we're trying out this new program. Would you be the guinea pig? Would you mind coming in and just talking and see what it's like for you? So the pharmacist did the first 3 back-to-back. 2 people with asthma came in, and then 1 person with diabetes. I was in the room observing, and there was wonderful energy in the room. I mean, can you imagine, think of your own personal pharmacist. There's limited time typically because of how many demands are on them. Somebody's on the phone, a technician needs them, another customer. But 30, 40 minutes just focus on them. So our customers really appreciated the time that the pharmacist spent with them. And what the training was the day before was pulling out someone's story in a narrative fashion. Pharmacists are wonderful multitaskers. But listening and sitting and drawing out someone's story and listening more than talking is not one of their strong points typically. And so that's one thing that Clint focused on the training the day before. So there was a 30-minute gap before the 4th person came in. And so Clint sat down with our pharmacist to debrief. And he was, our pharmacists were pretty jazzed because things were going so well. And Clint kind of bust their bubble pretty quickly. He said, this is not what I'm looking for. He said, here's what's happening. And the pharmacist didn't understand why. I said, why? This is going so well. They're enjoying this. And, there's good conversation. There's good energy in the room. And Clint said, here's what's happening. He said, your customers are telling you things that are partially true about their condition or just inaccurate. And as a pharmacist, you can't help yourself. What you're doing is interrupting. Let me correct. Now, let me tell you the study to back it up. Now let's go forward. He said, what's happening is a start and stop to the conversations. He said, what I'm really looking for is a flow of the conversation. And I remember Clint just kind of putting his hands up, and he just said, let me just do this last one to give you an idea. The last person to come in was a woman who was in her latter 20s. She was a surgical nurse at a local hospital. And so she sat down. She had been diagnosed with type 1 diabetes since college, so maybe insulin dependent for 7, 8 years, something like that. She sits down. The first thing she said is, I really don't need to be here. She said, my blood glucose and my hemoglobin A1C is where they're supposed to be. I exercise every day. I eat right. I monitor my blood glucose. I'm taking my insulin. Honestly, she was really doing everything that she was supposed to be doing. And honestly, for most of our competitors, she'd be the poster child for compliance. Clint said, way to go for doing what your doctors asked you to do. But you haven't lived with diabetes your whole life. We've got some time. Do you mind just sharing with me what that's been like for you to live with diabetes, for the last several years? She starts to talk. Now, again, this is a clinical psychologist who's leading this conversation. And it's almost as if the 2 pharmacists and I just kind of blended into the woodwork. The trajectory of the conversation was so different than the other pharmacists. The pharmacist's trajectory is up here, a lot of energy, good conversation. Clint's conversation got very personal very quickly. And she started to reveal things that kind of surprised me sitting there. And I remember her telling, and she's a beautiful girl, never been married, and she said, I don't tell guys that I date that I have diabetes. So I don't come from a family with people with diabetes. So I wasn't sure what she was talking about. She went on to say, I was playing tennis. It was August. It was hot and humid in Fayetteville, Arkansas. And she said, we played a couple sets. I was dating a physician at the time. He didn't know I had diabetes. She said, my pride kicked in. He wanted to play a 3rd set. I started to feel unstable after 2, but I went ahead and played the 3rd set. And she said, I almost got myself in serious trouble. As you all know, there's some bad things that can happen if you push through that wall. And she said, we do amputations every week in the OR with people with diabetes. She said, I've yet to see a woman who's 60 years of age have diabetes for 40 years and actually be intact, which would mirror the circumstances of her life. And she looked at Clint and she said, I'm damaged goods. I have diabetes. And she starts to weep. And it's just this mock conversation. And the first thing that I thought of, honestly, was you're smarter than that. You're a registered nurse. You understand, honestly, you got to believe that the people that you're amputating on have ignored their disease for 40 years. That's why they're being amputated on. You're taking care of yourself. You're going to be okay. Clearly, it didn't matter what I thought, and it didn't matter what the physician thought. And could you ever imagine her disclosing that to a physician, a surgeon in surgery? I'd probably judge her harshly and instantly. She wouldn't, make her feel like she wasn't very smart. So what was interesting was, for me, kind of the heart and soul of Trestle is birthed there. And I think this is so relative to everything we're talking about, or we'll talk about Trestle Tree. If this point is missed, I think we miss everything about Trestle Tree. It is the sense of, can we build the skills into health professionals so that somebody is willing to put their stuff out on the table? And they're welcome to do it. They're not being judged. That's the messiness of life. They're not being judged by it. They're not being shamed by it. They trust them enough to put their stuff out on the table. Now that sounds pretty easy to do. It's not easy to do. I mean, we work with construction companies, trucking companies, male-dominated, very macho, testosterone-driven industries. Those are people that are not easy to be vulnerable and put their stuff out on the table. But if you have the skill to connect with someone and they trust you with your first response, that's what she did with Clint. She trusted him with his first response, that he wasn't going to judge her or shame her, but she was going to be honest. Probably someplace in her mind, she knew that it probably wasn't logical that she felt that way, but that's how she felt. That's what we have the chance to do every day, is the ability to have health professionals that are trained in this model be able to connect with other people to help them change behavior that they may not have ever thought that they could. I remember I was walking through our coaching area. We have coaches across the country, but I was walking in Fayetteville. We also have coaches there at our office. And Ellen was a retiree. She was 68. She's one of our coaches, and she let out this hoop and holler. And so I came back, and I said, all right, Ellen, you got to tell me what just happened. And she said, well, I've been working with, as the retiree with the school district. She said, I've been working with this person. She was 70 years of age, and she had diabetes. That's why Ellen was coaching her. And she said, we talked for about 6 months before she ever disclosed to me that she had been smoking for 60 years. She started when she was 10 years old and it never stopped. But she withheld that information for 6 months because she was ashamed. She finally came clean, told Ellen. And the hoop and the holler was, this was the first month she had been smoke-free for 60 years that Ellen helped her. So I probably don't need to disclose this because it is being recorded, but I'll still do it, Paula. My first response was, she's 72 years of age. The damage probably been done. If she likes to smoke, why doesn't she just keep smoking? It's not the right answer. But that's honestly what I thought. So I told that to Ellen. And you know what Ellen's response was? Ellen's response was, she said, no, she said, she just told me, she said, do you know how proud my grandkids are of me? There are reasons you change behavior when you're 72 years of age that may not always have to do about your health only. It's that sense of passing on to your grandkids. And I think there are some things that would be interesting to think about that we have thought about. We have not acted on it. The training that we do is tremendous. It really is outstanding. We've trained folks, and we believe that there are elements of the training that we have trained people in with some health plans that we work with on customer service representatives. It's not a health coach, but it's somebody on influencing skills, on how to communicate different, on how to deal with an upset customer or an ambivalent customer, whatever that might be. What we have talked about is the ability to be able to provide training to the elderly who still have, an desire to work and to give back. My dad died 5 years ago. He was 79, full of life and health and still doing consulting. He was a civic engineer, a civil engineer, and was in a car accident and unfortunately was killed from the injuries in that car accident. But I think of Dad and how full of life he was at 79. And he influenced others and gave back. And it was really more through the church that he went to, the people that he mentored, a lot of young couples. And I think about the ability for seniors to be trained in the Trestle tree model, to be able to talk with other seniors, to be able to help people change, to be able to work with pre-seniors and that generation before, or even grandkids. When you look at the role that health plays on aging, it's something that I was telling Jim earlier, a friend of mine is a retired executive in Northwest Arkansas, and he retired about 75 years of age. And I remember I was talking, this is probably 15 years ago when we first started Trestle Tree, and very successful businessman. And he just said, Ted, he said, you know, at dinner when I say grace over the food and I thank the Lord for my health, he said, it actually means something now. And so I think, can we get ahead of that? Can we change? And what I have seen with retirees is the ability, without question, to change behavior. And the ability to step in and to influence your loved ones and the ones that live around you. So I think there might be a conversation that maybe we can have at some point, Paula, about trying some things and providing some training, if that's something that would be of interest to anyone, to be able to pass that on. So the training is the critical part for us. The outcomes are critical. So it's one thing to have a story, but it needs to be a good story. And the good story is that actually it's successful in helping people change behavior. And so what you'll see in these couple slides here is just if somebody came into Trestle Tree's coaching program, had diabetes, for example, and their lab results were above where they needed to be, they were high. What happened to them? And so what we've seen over the last 17 years, we've been tracking book of business outcomes, is for 2/3 of the people, they moved their hemoglobin A1C down 1.6 points. And so 1% drop is a 40% reduction in cardiovascular risk, and this was 1.6, a little more. 8 out of 10 people with cholesterol did the same thing, and same thing with blood pressure. It's an effective program at helping people actually change behavior. So what we do is we work with people around goals, around nutrition, exercise, stress. We work with people around medication adherence, monitoring of the condition, any type of a goal area that their physicians ask them to work on. We work with them on. One of the goals that we have is called Life Joy, and I think it goes hand in hand with Dr. Rosenfarb's talk today. And we call it Life Joy. And so what typically happens is the first conversation is much more about the coach listening around the holistic component of their health. So it is about their health and what their doctors ask them to do around their conditions they have, but also around family, around socialization, around finances, around stress, around work or family or home, whatever that might be. And so the coach is drawing all that. But we have goals around nutrition and exercise, medication and monitoring. And so we'll set collaborative goals based on where someone is and where they need to go to. As we call it match and move. You take one step forward with this and then continue to move forward on where you achieve the evidence-based guidelines goal. So we do that for the first 30, 40 minutes, and then the health coach asks someone a question that is a little unusual for a health professional outside of behavioral health or mental health. And the question is, what are you doing that brings joy into your life? And so most think in terms of men, think in terms of a carpenter that we may be dealing with, and he'll say, well, what do you mean by that? And the coach will say, well, what are you doing just for yourself that when you do it, it makes you feel alive? And so our coach listens, and oftentimes there's a lot of silence. And then they'll say, well, here's what I'm doing for my family, here's what I'm doing for my career, here's what I'm doing for my church and other things I'm involved in. I'm really not doing a lot just for myself. So the coach stays on and says, think back. What have you stopped doing that you used to love to do? And so we have a goal right alongside taking medication and losing weight and the other things that need to be done around doing something just for yourself. Research is pretty clear that when you feel like you're pretty good at something and doesn't cost any money to do, that if you engage in that activity, it wards off secondary depression. And so there's a lot of people that we work with that have lifelong conditions or lifelong struggles with health that secondary depression is there. We're not mental health providers. We don't cross that line, but certainly try to help people take on good habits from the life joy perspective as well. And it's life-giving what occurs when people start to take care of their physical health, but also their mental health at the same time. You can see those results as far as weight and tobacco. One thing I will say about tobacco is that we have a program that is really almost twice the national average as far as quit rates. Somebody quits, it's did you stay quit 6 months, did you stay quit 12 months? And our intent to treat, which means if 100 people quit in January, you send out some type of email or a letter to them in July and say, did you stay quit or not? And at that point, if 50 respond, and you have 25 of those that stay quit, the responder method would say, okay, it's 25 over 50, so that's 50% was a quit rate. What we have to do with the most academic way to do this is actually that it's the denominator's 100. All 50 that didn't respond, you have to choose, or you have to say that they went back to using tobacco. Even though you don't know, you have to. So the 53% quit rate is 28% is what the national average is, and ours is almost twice that. And then the 12-month quit rate is closer to single digits, and ours is at 40%. When you help somebody make a change that they own and that they truly change behavior, it's that sustainability that's the most important part, specifically with tobacco cessation. So I had some stories I was going to tell you. I told you about Ellen's person already, but a couple other stories I just wanted to share. Cindy had a retiree from a school district, different, and she was a tobacco user as well. And she'd been smoking for 50 years, not 60, but 50 years. And Liddy quit. So we did this video, and I didn't think to bring the video. It's a little bit grainy, it's pretty old, but it's this wonderful, sweet woman who was in her 70s and had smoked for all these years and had emphysema. I mean, really did have some serious health issues, but she wanted to quit using tobacco. And so Cindy was her coach and helped her quit. And when Cindy was interviewed, she said, when Liddy started, she said she had zero belief that she could quit, that she had no belief whatsoever. And Cindy worked with her and helped her, and move forward, and she ended up quitting. There was and this was probably 15 years ago, it was quite some time ago. There was a social network that was online, that she liked to be online. And so she wanted to have that connection with people who are trying to quit using tobacco as well as having the coach support. She wanted that online support. So Cindy sent me, 2 years after Liddy quit smoking, Cindy sent me an email. And she said, hey, just wanted you to know that Liddy died. I mean, you can't reverse all of that damage that you do in your body. But what she did was she sent me probably 20 to 25 different tributes that she had downloaded from that website of people that Liddy had helped stop using tobacco over those 2 years. It was a wonderful story about that component of making the change, but also having the ability to do something more with that as well. Jennifer, one of our coaches, had a veteran, and I had the privilege of meeting him and talking with him. And he was 65, was getting ready to retire. He'd been a truck driver his whole life. So he stepped in and he started coaching. His two grandsons, the touch point with the grandsons were golfing. And he couldn't walk the golf course because he was so out of shape and heavy and so forth. That was his goal, was to be able to walk 18 holes with his grandsons and to be connected more with them. So she started to work with him, and he did that. And so he'd lost like 35 pounds and was walking, was able to play golf and walk around. When I talked with him, he told a very heartwarming story. He said, I was a veteran. He said, I was injured on the battlefield, and he said, my best friend carried me off the battlefield. He said, I've told everybody my entire life that Mike saved my life. And he said, now I tell them that Eleanor saved my life. And so it was actually not Eleanor, it was Jennifer. Jennifer saved my life. It is that sense of how much people value the ability that they can make that change. And honestly, guys, not everybody's like Grandma Kay. She never had a coach. She was wired a certain way, and she was able to do it on her own. Most people are not wired that way. Most people need a little bit of help. And I think that's the component that we can reach out and give that little bit of help to people. So in the last few minutes here, what I'd like to do is just talk about a couple of things that we're doing with the training program, with Trestle Tree, with our coaches. And one of them is around the opioids. And it's hard to pick up a paper without hearing something about opioids today. We were fortunate that one of the leading research pharmacy schools has a PharmD PhD that developed an algorithm looking at medical claims and pharmacy claims and demographic information, and came up with an algorithm that was able to show the risk of an entire population before somebody was even prescribed an opioid of that individual. And so for you statisticians, the coefficient of determinants is at a 0.9 to a 0.93. Perfect is 1. And so it was can't truly say 90-93% accurate, but it's that type of very effective tool that is able to predict. So we have that we're starting, so we've acquired the exclusive rights to this algorithm. So we're starting to take our company's data and push that through that to be able to identify if somebody has risk, if they have surgery, and more than likely they'll be put on an opioid if they go through the surgery. Is there a higher risk for them to hit the slippery slope or not? It's interesting on how quickly this happens, as you all know. And I think a lot of the data that's been out there to date has been more on the kind of the working age. But the seniors, I've got a slide here that talks about, that the seniors have, 1 in 3 Medicare members with drug coverage were prescribed an opioid in 2016. The number of people over the age of 50 doubled, over the 12-year period, from 2002 to 2014. What's interesting is we did an early accountable care organization supporting physicians with Medicare patients several years ago. And so the patients that did have the drug coverage, we got their pharmacy data. And so we created some physician reports that we sent out to the physicians that we were supporting to be able to have the high risk handed off to Trestle Tree. And what was interesting was I asked our IT guys, I said, look, just take a high risk person, a medium risk, and a low risk person with their 4-page document we'd send to the doctor, and just de-identify it so that I can show people what this looks like to different physicians that I'd be talking to. So the high risk that they looked at, the individual was on a lot of medication. The thing that stood out to me, now this would have been 8 years ago, so well before the front page articles on opioids like we have today, but 4 physicians, 4 scripts for hydrocodone. And there was no PBM to be able to catch that. So you had a retiree who was doctor shopping. And I don't have the information in front of me, but I would imagine those 4 scripts were probably filled at 4 different pharmacies as well. I mean, if you hit that slippery slope, it's a tough slope to hit. And especially if it's something that the older you get, the more aches and pains you have. And opioids do control pain, and it controls a lot of the other type of pain as well when people take them. So the one thing that I do think that we have a chance to do is to not just bring awareness, but to be able to kind of help identify somebody who may be higher risk, and then apply the Trestle Tree model to be able to help somebody make sure they don't hit that slippery slope. So the pharmacy school that developed this had 2 different data sets. One was from NIH, one was from Truven, data warehouse for the medical industry. 4 million opioid users, some of them retirees, some of them younger. And what they looked at is, they had the 4 million opioid users, said, let's look at everybody that became addicted, and then let's stratify that population, and let's look at the worst 10% that became addicted with opioids out of these 4 million people. And then let's go back in the claims and see what dose they started with to begin with. What dose do you think it was? 30 days? 60 days?
30.
Yeah. So 82% of the worst started on 5 days. It can happen that quickly. So for yourself, please be aware that if your physician does put it on, you don't know about yourself, if you'll be one of those that could be impacted that quickly. The other thing that I would encourage is also the medicine cabinet. There are a lot of folks that have opioids that have been prescribed for a root canal or a surgery, and they've just kept the medication on, and they keep it in their house, and that's a real problem. I was talking with a physician who said that 70% of the, and I'm not going to probably get this just correctly, but he said, what he said was 70% of people who become addicted to opioids do it through the medicine cabinet. And where they're getting somebody else's medicine. So somebody can come into your house and look in the medicine cabinet, and it's typically kids who are doing some of those things as well. So just be cognizant. There are different retail chains now that are giving disposal packets and so forth to be able to destroy the opioids that are not used or not needed. So I would encourage you to think about that as well.
Is there any tendency to prescribe fewer doses? It's so common to get it's common to get a 30 dose prescription, and I understand take 3 or 4 and then it sits in now it's out there. So for the rest of the family and the kids and everything else. I would think there would be a trend of under-prescribing. Prescribe 2 or 3, and then if you need more, prescribe 2 or 3 more. Is there any talk about that?
There's a lot of good work that's being done right now, Jim, on the legislation within each state. So I think there's 32 states that have already legislated the maximum number of days that the physician can prescribe, bar some circumstances like palliative care, cancer, those types of things. But even at 7 days, because of the research that's been done, it still could be too many. And so I think there's, without question, I think there's 10% less opioid pills in the marketplace today than there was in 2016. Because of these types of pushes, physicians can't prescribe as much on a single prescription. So I think it's helping, but I was at an opioid conference in July here in DC, and one of the leading researchers from the CDC stood up. And again, I think we get numb a little bit to it. And you can't listen to NPR, pick up a newspaper, or read a news feed without hearing something about opioids. So I think we sometimes think, well, everybody's talking about it, something good's got to be happening. She stood up, and the first thing she said is, the opioid epidemic is just awful, and it's getting worse. We have not slowed this down at all. That's scary. As much awareness as we have right now, and you got 32 states that have already limited, and she said we haven't touched it. Another researcher from Thomas Jefferson University Hospital stood up, and he said it'll be at least 10 years before we get a handle on this. 10 years of the type of deaths that we're seeing on overdoses. We would have far fewer hands if I said, raise your hand if you don't have any personal knowledge of somebody who's overdosed and died. We all have stories about either our family or we have friends that have had family. It's just such a crisis. And a lot of kids are getting screwed up and overdose on things. Anyway, we could be up here the next 2 hours telling stories. But it is something that I do want to encourage you all to be aware of, which I know you are aware of. But there's something that really can be done. And those are the things that we're training our health professionals with, that 200 hours of training, and then they get certified by Harvard Medical School with a certification in opioid addiction through the Global Academy. And then our coaches are trained for another 24 hours with PhD psychologists on how to help people who have a higher predisposition to hit that slippery slope, not hit the slippery slope on opioids. So we're doing some things right now with foreign service around pre-search on surgery and talking with somebody before surgery and then scheduling afterwards with their caregiver to make sure that people are managing pain and looking at alternative ways to manage pain as well. We are not the opioid police. We don't say just no. That's not our place, that's between the physician, but we can help people manage them properly. So, and this was part of Brad's work, who did this was off the CDC site, but some of the research, the guy who developed this algorithm, showed that at 7 days supply, there's almost a 15% chance you'll be taking an opioid 12 months later. 11 days, it jumps to 25%. I mean, these are not small odds at all on how dangerous these drugs can be and how quickly that slippery slope. So do seek the help that you need on the opioids. This is the program that we're doing, Paula. So I'm about out of time. I won't go in. That you have the slides on musculoskeletal. That there's a lot of things that you can look at in data to identify when people are start to be put on opioids. That is a good place to intersect. And so for us, surgery certainly is one of those. But then beyond that, there are other places you can look in the data as well. So thank you all for your time, and thanks for all your work to live healthier, and just know that it's not only for you, but there's some other folks that could benefit from you being healthy as well. So thank you.